Dr. Lachmann trained in medicine at the University of Cambridge and at the University College in London in 1999. Following postgraduate training in internal medicine and nephrology, she started her research in amyloidosis. She is president of the International Society of Autoinflammatory Diseases and leads 2 national highly specialized services, the UK National Amyloidosis Centre and the CAPS and Systemic Autoinflammatory Diseases Service. She has published more than 300 papers, and her main scientific interests are focused on the genetic and management of the systemic autoinflammatory diseases and characterization and treatment of acquired and hereditary systemic amyloidosis. Dr. Lachmann is going to give a talk and then take some questions. You are welcome to submit questions through the Q&A feature at the bottom of your screen. We would like you to submit questions that do not include any personal or clinical information. Make sure that your questions are generic in nature, and she is willing to take them throughout the presentation or at the end. So without further ado, I turn the screen over to Dr. Lachmann.
Thank you very much, and thank you for the introduction. I'm sorry about the background noise. I'm in the middle of a big city on a hot day, and my neighbours are doing building work. So I'm going to give some slides to begin with, just really to get things going. I'm sorry they're a bit technical, but it's really to show what we know so far and just how many holes there are in it. So I'm really going to talk about fertility, pregnancy, breastfeeding, and to some extent about male fertility as well in the autoinflammatory diseases. And it's going to be a bit biased towards familial Mediterranean fever, because that's the commonest disease. And that's just where there is most information to give you. But a lot of the lessons from it can go to the other diseases. So the background to this is, as you all know, the autoinflammatory diseases tend to present in children or in young adults. And then once they've presented, most of them, particularly the genetic ones, will require indefinite treatment. Because treatment has been very successful, and the philosophy of our clinic is that for the majority of individuals, we're trying to talk about leading a normal life and an expectation of a normal quantity of life, but also a normal quality of life. You cannot dodge questions about reproductive choices, because that's really important as a part of adult life, that you can make those choices and that you can plan having a normal family life if that's what you want. So questions about compatibility of treatment with pregnancy and with having children really arise very frequently. And these can become very difficult because systematically, pregnancy and lactation are excluded from trials of new drugs. This is absolutely part of every single new drug study. And then even after the studies, manufacturers will almost always discourage use of any new drug in pregnancy or lactation due to essentially absence of data. So absence of evidence of proof, which doesn't mean that we think it's unsafe, and to fear of litigation. So if you look in the packet of any drug, it will say, don't use this in pregnancy. In addition to that, advice in drug formularies, which is what comes from the regulatory authorities such as the FDA, usually doesn't change even when data from case reports, drug registries, or controlled studies are reassuring. So the data the advice that is given is very, very conservative and lags behind clinical experience by many years. That means that for all the drugs that we use, if you just look at what the drug companies say, and to some extent what the regulatory authorities say, it's very unreassuring. And when I started to do these clinics, we were left in a situation where I seemed to have an increasing number of patients who are reaching reproductive age and contemplating starting a family. And for patients with well-controlled disease with an expectation of a near normal duration and quality of life, information concerning their fertility and the potential risk to themselves and their children was of enormous importance. And I didn't have anything to give them. And when we said that we would support pregnancy and we would support people planning families, we were essentially doing this on a risk-benefit discussion with each patient with nothing to back us up about whether this was a good idea or not. We've now been doing this for about 25 years. And we have large numbers of children who've been born to patients in our clinic, and it's something which we have got increasingly confident about. But in order to provide guidance to patients where one pair in the partnership is considering pregnancy, you need to be able to talk about the risks of the parent. This is particularly the parent who's pregnant, so short-term risks such as short-term disease flares, but also long-term risks in terms of are they going to get damaged through the pregnancy. And you need to talk about risks of the potential child. And when you're talking to people who want to have a baby, they tend to be very, very focused on the risks of the child. One of the responsibilities of the doctor is to be quite concerned about the risk to them and to try and balance those two. And how do you think about this? So I trained at UCL, which was one of the things that Fiona said. And University College London was founded by this man, Jeremy Bentham, who I'm afraid is literally stuffed and in the main corridor of UCL. So this is a photograph of him stuffed. He's been very nicely redone, and his clothes were redone a couple of years ago, who is in our main building in the quad of UCL. You can go and look at him if you're in London. And he was a utilitarianism. So he believed in supporting actions that promoted the greatest happiness for the greatest number of people. He was a founding member of this branch of philosophy. And to some extent, this tends to be how I think one should think about this. So in medicine, we tend to think about risks as being risks either of not doing something, which is risks of omission, or of risks of doing something, which is risks of commission. And as doctors, we're taught that risks of commission, which is doing something, are always worse than risks of omission, which are not doing something. It tends to make us very conservative. We're taught it's always worse to do something and cause harm than not do something and cause harm. That gets very difficult if you're talking to people about these choices, which are always nuanced. And to some extent, I think here utilitarianism is a better approach, which is to say, what is going to be the outcome that you think is going to be best for the greatest number of people when you don't really know what the right thing to do is. That, to some extent, is the approach that we've tried to take. So with that as background, just before we go on to pregnancy, I thought I'd also talk briefly about care of teenagers, which in medical speak is referred to as transition. And transition is the care that tends to start at the end of childhood, tends to be defined as about age 12, though it is very dependent on the child, and when they are really reaching the end of being a child and becoming a teenager, until they are established thoroughly into adult life. And although that is not defined as 18, that for us tends to be defined as mid-20s, so probably about 26. And there is this period of time when they are not children, but they are not yet fully grown-up adults, where they are often, certainly in the UK, quite poorly served. So there's really, really good pediatric care, there's pretty good adult care, but this period in between, when you are not a baby or a small child, but you are not yet an adult who can be left to fight it out in a general hospital, is quite a difficult time. And it really, really matters in chronic disease because it is the time here which establishes whether you're going to work well for you the rest of your life. So this is something that medically, in terms of organisation of service, we're increasingly interested in, because if you drop the ball here and you leave children either too long in paediatrics or move them too quickly into adult care, they tend to get very neglected by both ends. And there's a problem that there's a lot of paediatric hospitals and there are very many centres who are interested in care of teenagers and young adults. So this is a formal process that should be planned and should involve both the child, their family and the medical teams, should be beginning to be planned by age about 13 and should be completed by age 18 so that they know that they've moved away from their paediatric doctors to their adult doctors. From the medical point of view, this needs to mean that actually everyone knows that care has been transferred and that everybody knows what's going on in terms of medical information, broader multidisciplinary care. So if anyone needs support from physio or psychology, basic things like, have they been vaccinated? Do we know whether they've been vaccinated? And then things that are really, really important, like if you're on an expensive drug, do the hospital that's taking you know about the expensive drug? Do they know how it's being funded? Do they know where the next prescription is coming from? Because if you're 15 and you shift hospital and they go, oh, we don't know where you're going to get your next dose from, that's a disaster. And this involves all sorts of things, so readiness and transfer and organisation, but it also involves moving them so that they come to a centre where people are prepared to talk to them about all sorts of things which you have to talk to teenagers about, and one of them is sexual health, as well as substance abuse and mental health, and move them across at a time when it's appropriate to start these conversations as part of chronic care. This is important because if you actually ask teenagers what their major concerns are, and these are health concerns, this is taken as a schematic from publication about the health problems affecting adolescents, taking out their chronic illness, things that concern them are common acute illness, but then also general symptoms such as fatigue, headache, back pain. So symptoms for which there isn't a clear medical diagnosis, mental health problems, and this has got very much worse post-COVID. Addressing health risk behaviours, so talking to them about smoking, drinking, drug abuse, road safety, sexual health, eating disorders, body dysmorphias. And these are all really important, and these are things that need to be dealt with in a sensitive fashion that is appropriate to each age. Part of this, and particularly in terms of managing chronic health, is talking about taking drugs. When we now talk about taking medication rather than taking recreational drugs, the favoured term is called adherence. Used to be called compliance, and the medical definition of compliance was I tell the patient what to do and they say, yes, doctor. This failed for all sorts of really obvious reasons, which is there's absolutely no point in somebody spending 2 minutes saying you need to take this drug and then imagine somebody's going to go away and take it if you haven't had any discussion about how they feel about that, what might be the problems with it, why they might not take it. So there's now a conceptual model called adherence, which recognizes that actually whether people take their medication or not is really quite complicated and isn't to do with control and command. So it isn't somebody saying do it, and if they don't do it, it's a failure on their point. It's looking at all the ways in which you can make this easier or harder from people, from ease of drug delivery and side effects and cultural beliefs to can you get it? Is it phenomenally expensive? Does everybody you know tell you that it's poisonous and that you shouldn't possibly be taking it? Does the pharmacist tell you that it's poisonous and you shouldn't be taking it? All of which make a big difference. There are some things that are very age specific and which particularly are important with teenagers. One of which gets tend to referred to as concrete thinking, and concrete thinking is particularly an issue around teenagers. We all have concrete thinking, but it's a developmental stage in early adulthood where it's really, really common. And concrete thinking is essentially something happened once and therefore this is the case forevermore. And I've taken an example here from asthma medication because I couldn't find one for autoinflammatory diseases, but with a child, a teenager saying, I missed my inhalers, I forgot them twice and I'm fine, so I don't need them. I have taken one example and I have moved it out to the rest of the world, and that is what I've learned. That's one example of concrete thinking, but another one is when the health service lets them down. You said that you would see me at 9 o'clock in the morning and it's 9:30 and you haven't seen me. I don't, you promised me something and you haven't delivered it to me. Therefore, I'm going to struggle with you forevermore because I'm quite young and you haven't delivered on what you told me. So you need to be very careful with this age group that you're very clear in what you say to them and you give them what you said you would, because it's very difficult if you're a teenager and somebody promised you they'd do something and they don't do it. And I don't know what it's like in Canada, but in the UK, the health service is absolutely chaotic and it's very difficult to deliver exactly what you said you would, but this is the age group where you've really got to do it. If you promised you'd do something, you've got to do it, or if you're not going to do it, you have to tell them beforehand that you're not going to do it. And for that, we rely on specialist nurses and on youth workers who can ring them up, text them, confirm that we are doing what we said we were going to do, or if we're not, telling them beforehand and telling them why. So you have to anticipate, you have to be rapidly responsive, you have to say what you're going to do. And it really helps that they have these people that they know well who can help with daily organisation. And then, because they're not fixed, they will also do what is called much more sophisticated adaptive thinking, which is that they come to recognise things are more complicated, but all stressed people tend to do concrete thinking, and stressed teenagers will do concrete thinking more And it's really important not to get in a fight with them because it tends to be everybody hardens down onto their points. So they're a group in whom we're really keen to address a number of specific issues. One is that we are supportive, we try and get them through adolescence, try and meet their needs in a pretty flexible fashion. The other one is that they are genuinely quite difficult to manage their drugs with because they're growing. And so you can leave it a few months and they're 10 kilos heavier, 6 inches taller, and the drug dose that you thought was fine is not big enough because they've grown. So you have to anticipate getting their drug doses up. You need to respect their autonomy, but also help them to recognize that they're going to have better autonomy if you can keep their disease control good, which is all around adherence. Have to address concrete thinking. You have to be sympathetic to the fact that we want them to have a normal adolescence, which means you want normal adolescent behavior, which is that they are not going to agree with you, they're going to be out partying, they're going to be experimenting with their sexuality, with drugs, with behaviors, and how you handle that. And as hormonal influences come in, their disease control, particularly with FMF with the girls, may change. And that's the one thing where we do see a difference between male and female in terms of hormone effects. Otherwise, I think these diseases are very, very similar, which is that you can see perimenstrual flares coming in and they may need to be treated differently. And I'll talk about that in a moment. So moving back to talking about here pregnancy when they're a bit older. When you come to talk about fertility choices and to talk about pregnancy in these diseases, it's a jigsaw. And what we think about in all the autoinflammatory diseases is trying to put the pieces of the jigsaw together. So when we think about treatment of autoinflammatory diseases and planning for pregnancy, what we're thinking about and what we try and talk through is the effect of the autoinflammatory disease, whether it will be affected by pregnancy, whether the treatment of the autoinflammatory disease will have an effect on the pregnancy. So what is the effect of the pregnancy on the disease? Will it get worse? Will the treatment be effective and safe? Will we have to change the treatment? What is the effect of the autoinflammatory disease on the pregnancy? Is the pregnancy likely to be higher risk? Is there anything we need to do about that? What is the effect of the treatment of the autoinflammatory disease on the pregnancy? Do we need to change that? Then we also need to think about what is the effect going to be on the child after delivery? Are there going to be any long-term effects of the treatment delivered to the parent during pregnancy on the child? Do we need to think about that post-delivery? Do we need to think about that in terms of breastfeeding? Do we need to think about genetic counselling? Gather your last session was on genetic counselling. And then we need to think about all of this in terms of maternal health. Is the mum's health going to be changed by the pregnancy? Is she at risk not just of flares for autoinflammatory disease, but of getting any other maternal health problems? And you have to think through all of these, and each of them has a relationship on the other one. So essentially, there's the baby, there's the disease, there's the mum, there's the child after the pregnancy, and each of them are to some extent an independent player, and you have to think about each of them to get both all together, but also all separately. It's not as difficult as you think, because fortunately, most of the answers we have for this are reassuring. So this is where I'm going to talk to you about familial Mediterranean fever, because it's the commonest of these diseases. It's the one for which we have most information, and it's the one that's been treated for longest. And there's been a very nice study of this published from our Turkish colleagues, which came out this year, and which is actually a summary of all published data. And this looks at the effect of familial Mediterranean fever on the reproductive system and what we know about it at the moment. So what do we know about the past? So if we look before the introduction of colchicine in 1972, this tells us about essentially what happens if we stop treatment. And that is really important to know, because one thing that everybody wants to know is, would it be better if we didn't take treatment? And it's really tempting if you are thinking about planning for a family, planning pregnancy, to think I'm being selfish and treating myself. This is a high risk to the baby. I should stop all treatment. that would be better for the potential child. That's almost always wrong, and we've got really good information for that. So what do we know about the past? We know that familial Mediterranean fever, as I said, is quite affected by female sex hormones. So perimenstrual attacks were very common. 15 to 45% of women in the pre-Colchicine era had perimenstrual attacks. We know that that can still continue, and that in younger women, particularly if they get more abdominal attacks, if there's any suggestion of associated endometriosis, this may be an argument for adding in a progesterone or contraceptive pill. We also know historically, pre-1972, and this will be an underestimate because subfertility is very, very sensitive, was very poorly discussed. So unless you directly ask the people affected, you really always underestimate subfertility. Their children, their siblings almost certainly don't know about a history of pregnancy losses, but it certainly affected at least a third of couples. This may have been due to pelvic adhesions, may have been due to ovarian insufficiency due to AA amyloid. It may have been due to the effect of attacks itself. When colchicine treatment was introduced, subfertility fell to about 12 to 15%, and that is the same as the normal healthy population. So familial Mediterranean fever in the colchicine era carries the same risk for couples of struggling with fertility as the normal population. And that is between a half and a third of what it was reported, which would have been an underestimate before treatment was available. So the bottom line from this is that fertility outcomes are much better if you're on treatment than not, and we think that's a lesson you can take for all active autoinflammatory diseases. Once you're pregnant, pregnancy loss in untreated FMF, so knowing you're pregnant and then losing the baby rather than struggling to get pregnant, was between 25 and 30%. And those who completed a pregnancy, so didn't lose the pregnancy, there was a risk of preterm delivery, so having your baby too small, and small for date babies, which is having your baby on time, but the baby is smaller than you would expect. And both of these have long-term poor health outcomes for the child for the rest of their life. What you want for a child is for them to be livered at term and in a good size. That sets them up well for the rest of their life. So untreated FMF before 1972, less likely to be able to get pregnant, less likely to be able to maintain a pregnancy, and if you did maintain a pregnancy, more likely to have your baby too soon or too small. What has happened since then? A number of things have happened. One is there have been a node of studies, and summarizing them, what we know is that colchicine usage is not an independent factor for fertility problems in women. So if we look at fertility, actually in both women and men, but I'll come on to men specifically afterwards, but if you look at women carrying the baby, colchicine usage does not come out as being a risk for being either unable to get pregnant or to sustain the pregnancy. So what we know is that in people who have FMF and are on colchicine, their pregnancy outcomes look very similar to healthy population. We think this is because active disease is prevented, and active inflammatory disease is extremely bad for being able to hold on to a pregnancy. So if you have active inflammatory FMF, you are more likely to have either a preterm delivery or to lose the pregnancy. And when the disease is controlled with long-term colchicine, that rate drops to the same rate that you see in the normal healthy population. And unfortunately, the normal healthy population, both struggling with conception and losing a pregnancy, is a pretty common experience. So 12 to 15% of couples will struggle to conceive, and 12 to 15% of pregnancies will be lost. So this never goes down to zero. Standard population rates are higher than any of us would like. We also know that delivering a baby too soon goes down to normal rates in patients who are effectively treated with colchicine. What we also know is that what happens to your FMF in pregnancy is a bit variable. So there are reported pregnancies in which FMF appears to settle down, and people report that they go through their pregnancy and they don't have any clinical attacks. Most of these patients were on colchicine, but attack-free pregnancy rates are reported at about 60%. There are also reported rates of having worse FMF during pregnancy, and there has been a paper doing an analysis of this, which says actually it's just not predictable. FMF can get better in pregnancy, FMF can get worse in pregnancy, FMF can not change in pregnancy, and essentially we don't think that you can give anybody any advice about what's going to happen to their FMF in pregnancy. The advice that we give everybody is that they should stay on treatment. There are a number of papers that suggesting that there are probably some increased antenatal complications if you've got FMF. There's a slightly increased cesarean Caesar rate and maternal hospitalization with some gestational diabetes, preeclampsia, and a bit of liver problems, which is when the liver isn't clearing the bile quite as quickly as it should. We don't know why. This may reflect the fact that these pregnancies are just a bit more medicalized. There's no convincing instance for this. Then there's one very, very small series which reported a higher instance of premature rupture of membranes, but that hasn't been duplicated by any other series, and it was tiny. So I think that has not been duplicated. And my computer is now stuck. Let me try moving a slide on. Sorry, I'm now stuck. One other question that comes up is whether colchicine damages the baby. And so because colchicine can affect how cells divide, there's been a question about whether colchicine itself can cause miscarriages or can damage the baby in terms of causing chromosomal or fetal malformations. This often comes up when people ask. And there have been a number of studies looking at this, and then there was a big meta-analysis 6 years ago. And the answer is there is no data to support this. The studies and the meta-analysis suggest that the odds ratio, which is the relative risk of having a miscarriage if you're on colchicine, is lower than if you're not on colchicine, and the odds ratio of having a baby with a major abnormality or chromosomal abnormality does not support that colchicine has any effect at all. So colchicine looks safe for the baby in pregnancy. So this has turned into some European League Against Rheumatism consensus recommendations for the management of familial Mediterranean fever in pregnancy, and that is that colchicine should not be discontinued. It should be continued all the way through, and that there is no justification for doing anything invasive to look at pregnancy. Pregnancy should be managed like any other one. We wouldn't recommend doing amniocentesis. People do need to be told that they're on a drug and what the risks and benefits are, and it's really important that they're told that clearly as early as possible, because it's not good to be doing this on a web search or to be being told it by somebody who's being alarmist once we're already pregnant. If you read the manufacturer's brochures, it tends to say don't do it, which is why you need to get your advice from the EULAR recommendations and from a doctor beforehand, because this is back to the problem about the literature really lagging a long way behind what we know, because there have been large scale reviews now of the data which show that there is no evidence that we can find of harm and there is evidence of benefit. We know that stopping colchicine carries a risk of damage. We know that if you stop colchicine, you're likely to get increased attacks of familial Mediterranean fever, and that those attacks can lead to premature contractions and to early delivery abortion. The other thing to say is that after 16 weeks, you can feel your baby moving. Having an attack of FMF when you can feel your baby moving inside you, if you're having an abdominal attack, is agonizingly painful. It's not good for the parent, it's not good for the baby. It is much better to be on treatment than to risk having an unbelievably painful attack and have your baby moving around and essentially kicking you from the inside when it's happening. We know that the risk of losing the pregnancy is greater if you don't take colchicine than in women who are taking colchicine and are pregnant. So we recommend continuing colchicine. There are some people who feel that their FMF has got much milder in pregnancy and who slightly decrease their dose of colchicine because they're finding that they're needing less to keep their disease completely controlled. As long as disease is completely controlled, both symptomatically and by blood tests measuring inflammation, I think that's perfectly reasonable. But we have seen that the stress of delivery, either a normal vaginal delivery or a cesarean section, can often kick off an FMF attack. So in people who have reduced their colchicine dose, my standard recommendation is that they put it back up to their usual dose 3 weeks before expected delivery, And that's because starting parenthood with an attack of FMF is a really bad start. And we try and avoid that by saying, have your levels back up to anticipate the risk of having an attack around the shock of delivery, so that you're not becoming a new parent with an FMF attack, because we'd rather avoid that. Colchicine is measurable in the breast milk. It's completely true. And there is a tiny amount of colchicine measurable in the breast milk, but it's very low. And there is no suggestion that the very, very small amount that the babies are exposed to does them any harm. So we don't recommend stopping colchicine during breastfeeding, and we don't recommend avoiding breastfeeding. We just say you carry on all the way through, and we treat women who are pregnant with their colchicine exactly the same as we would somebody who isn't. We titrate their dose against their disease activity, and we aim for completely controlled disease activity. So in summary, multiple studies have demonstrated outcomes in colchicine-treated patients comparable to the normal population. Pregnancy outcomes in patients who use colchicine regularly before and during their pregnancies are the same as the normal population, so we do not recommend changing colchicine doses in pregnancy. We encourage normal delivery. We don't think that you need to do anything special. We don't recommend cesarean sections. We think people should be treated exactly like everybody else. There are no specific indications for doing anything different. For most people, we wouldn't predict that the clinical course of their FMF is going to be any different during pregnancies, and we wouldn't change their drugs based on that. People who've got much worse tend to be people who stop their colchicine. Right, and I've just said colchicine in breastfeeding. Colchicine, the data suggests, is completely safe in breastfeeding. About 10% of the colchicine does end up in the breast milk. There's no suggestion that that does any harm to the babies at all. And there's been a small study comparing babies where they were exposed to breast milk in the colchicine in the breast milk and those who weren't. There was no difference between them. AA amyloidosis is the most feared complication of the autoinflammatory diseases. It's very, very rare to be able to get pregnant in the face of AA amyloidosis because it causes significant renal disease. It probably also, you get a bit of AA amyloidosis in both the gonads, so in the ovaries in women, in the testes in men. That probably is a direct cause of subfertility. There are very, very few case reports. When this happens, they need to be co-managed with the kidney doctors because this is often a case of pregnancy in the face of renal disease. These are difficult, high-risk pregnancies, but we don't think the FMF is the problem or the traps on the caps. The problem is the AA amyloidosis. We've had a very small number of pregnancies where this has happened in London. So far, they've all been successful, including one which was a twin pregnancy. And what we do is we continue effective treatment all the way through. But these are highly medicalized pregnancies where they are watched very, very carefully because we're concerned about risks to the mum in terms of risks to their kidney function, risks of high blood pressure and preeclampsia. We're concerned about risks to the baby, that they need to be growing well. And this is something that is very rare and it's managed with extreme care. But this is not something that we would take backwards and say is in any way a risk to most people who don't have a complication of AA amyloidosis. I would also say that AA amyloidosis is a disappearing disease. When I started 25 years ago, it was about 20% of the amyloid that we saw in the UK. It's now less than 2%. With well-controlled disease, people just don't get amyloid. So what about male fertility? There are very few systematic studies. So there may be problems and potential causes. What we worry about with male fertility is high attack frequency and inflammation, which is exactly the same as female fertility. It's not good for fertility for any partner to have a high attack frequency and a lot of inflammation. There are case reports of infertility due to testicular amyloidosis resulting in a failure to produce active sperm. There is very little to suggest that colchicine is a problem. So when you look at large-scale studies, colchicine doesn't seem to have any effect at all. There are 1 or 2 case reports in which people were on colchicine, had problems with sperm counts, stopped their colchicine, sperm counts improved. The difficulty with this is that generating sperm is complicated and recommended changes in lifestyle for many men will improve their sperm count, and it's always a bit difficult to know whether it's stopping a drug or whether it's many things that were done at the same time that make a difference. So general advice is that men do not need to stop colchicine prior to conception. There have been some studies which have looked at sperm evaluation in patients with FMF on long-term colchicine, which have suggested that the sperm evaluation is exactly the same as healthy controls. A very small study of 6 healthy volunteers who received normal doses of colchicine for 4 to 6 months suggested that sperm generation was completely normal. So in general, it's thought that if there are poor sperm counts in patients who are taking colchicine, it's due to the underlying disease for which they're taking the colchicine, which may be AA amyloidosis, may be active inflammation, and the best approach is to control the underlying disease better. If it is seriously thought that somebody has an exceptionally rare individual reaction where colchicine is causing a drop in sperm count, which can happen with any drug, then it's reasonable to discontinue the colchicine, try something else, reassess the sperm count, and see what happens. Because sperm is made, stored, you can do that within about 3 months. If that is the problem, then colchicine should be restarted after successful conception. What about the other anti-IL-1 agents, which are what we tend to use to treat colchicine refractory FMF, but also TRAPS, CAPS, mevalonate kinase deficiency? So we tend to use anti-IL-1 agents, and what we tend to use is anakinra, Kineret, canakinumab. In Europe, we don't use rilonacept, so I can't really give you much data about rilonacept because we have never used it in Europe. When drugs are classed by the FDA, in terms of pregnancy risk, they're cast on a score that goes from A to D. So A is essentially paracetamol, Tylenol, and 1 or 2 other drugs, which is there's a really good evidence base that this drug is safe. It's a very old drug. Lots and lots of people have been exposed to it. We know it's all right in pregnancy because there's been lots of people who've been through pregnancy before you, and the theory looks good. D is do not do this. In theory, it looks bad. In practice, it's bad. That's chemotherapy agents. That's thalidomide. That is, there is a really, really high risk of irreversible damage to the baby. Do not get pregnant under any circumstances. And then in between, there is B, which is we think it looks all right, but there just isn't enough data. And there will never be enough data because too few women are going to get pregnant on this drug that will ever be able to give you 1 in 10,000 or 1 in 100,000 risks. And C is there's a little bit of data that suggests it's probably not a good idea, but we don't have enough data to be sure. Anakinra is categorized as FDA category B, meaning the animal data looks absolutely fine, but there are no adequate or well-controlled studies in humans. And anakinra is a copy of a molecule that humans make for themselves. So you're getting a bigger dose of something that people make for themselves anyway. Canakinumab is a manufactured antibody that doesn't look like anything the body makes for itself. It's FDA category C because there were some problems with ossification, with completing bone, which was done a bit late in some animal models. So marmosets were fine, but mice, there was a bit of delayed ossification of the cranium around the brain, but nothing that suggested a serious problem. So that's what the regulatory authorities tell us, is that neither of them look dreadful, but anakinra is potentially a little bit safer than canakinumab. So the prescribing information that you get, if you look in the back of the packet, is advice should only be used if clearly, Kineret should only be used in pregnancy if clearly needed, and you should be cautious about breastfeeding. Canakinumab, the advice is that there is concern, that risk benefits should be considered, but you really shouldn't do it in pregnancy. There's no information about breast milk, and it makes a very good point here about live vaccines, which I'll come on to in a moment, which is that canakinumab probably does cross over from them across the placenta in the last third of pregnancy, and that would make a difference, or might make a difference, to the ability to respond to a live vaccine for the first 3 or 4 months of life for a baby, and has a bit of an effect going on for the child at the end of pregnancy. And rilonacept is very similar, but again says you need to have a risk-benefit discussion about how to use it. So what about non-FMF and FMF when you need to use these drugs? So it's very hard to quantify the risks outside FMF. So as I said, it's very difficult to know what the risks to pregnancies were from old data, because all we have is old papers. And to be fair to my colleagues, many of these are quite old and were written by men who were asking women about their pregnancy history. And if you go back and you ask the children of people who have subsequently passed on or their siblings, they won't know, because this is something that historically often was not discussed. These are very, very sad and private events, and it's quite difficult to discuss this with people. And you wouldn't know whether your mother had a very difficult maternal history, and whether you were one of many attempts or whether she'd had a very easy time. So we think the miscarriage rate was reasonably high, perhaps in caps as high as 30%, but it's very unclear. We assume it was at least as high as FMF, and it's very, very difficult in retrospect to clearly differentiate the effects of disease activity, previous treatments, because many of these people were on very toxic treatments which didn't help very well, or deficiencies in maternal care at the time. But these families often report a very long, generational, sad time having children. Nonetheless, both TRAPS and CAPS are autosomal dominant diseases, so clearly did manage to go down through the generations. So what data is there? There have been a number of different meta-analyses looking at exposed pregnancies to particularly anakinra, but also to canakinumab, and this has resulted in some advice. So I will confess to you, a lot of this data comes from work that was driven initially from London, and then from a drive when I stood up at a meeting and said, we all need to talk about this and we all need to start collecting our data. Because of that, and because I initially favoured anakinra, most of the data comes from anakinra, and this has become a bit self-fulfilling. Because we have reassuring information about anakinra, we now, as a consensus, say that we would much rather have people on anakinra, which is a copy of a protein that everybody makes for themselves, which in theory is safer, which is short-acting. So the advice is that people who need an anti-IL-1 agent should be on anakinra, and as time goes by, we get more information about anakinra, and that strengthens our view that the drug used should be on anakinra. It's not that we know anything particularly worrying about canakinumab or rilonacept, but they are in theory a little bit less safe, and we are gradually accumulating more and more information about anakinra, which is in theory the safer drug. So anakinra now, the literature has about 69 pregnancies, 80 in the most recent paper, but we, between us now, will know about more than 150 pregnancies. And the majority of these pregnancies have resulted in a healthy live birth. Not all of them, because these are quite complicated pregnancies. Not all of them are straightforward autoinflammatory disease. Some of these patients have much more complicated diseases. In our experience, the autoinflammatory diseases are actually less complicated than the other ones. There have been 2 reported pregnancies in which there was a failure to develop kidneys. There was one twin pregnancy in which one twin was fine. The other twin didn't develop kidneys at all. That is not compatible with survival, and sadly the baby died before they were born. And there is one reported pregnancy where only one kidney was developed. You're absolutely fine with one kidney. The kidney that is developed compensates, and it's a nice big kidney. 1 in 10,000 pregnancies are lost because of a failure to grow kidneys. 1 in 5,000 babies are born with only one kidney. We have not seen enough pregnancies that we're just going to go, that was chance, but we have not seen this again. When we went back to the embryologists and said, tell us about the role of interleukin-1 in the development of the human kidney tract, they said, there is no interleukin-1 in the development of the human kidney tract. It doesn't play a role, so we don't think it's linked. Might have been the disease, it might have been chance. We specifically discussed this with everybody. We say that's the only flag so far of concern. There are various consensus advice. There's beginning to be consensus advice from EULAR. This is the British Society of Rheumatology, which recommends that after an evidence discussion and a risk-based discussion with the parents, it's reasonable to continue treatment with these drugs, and that the first trimester, which is the first 3 months, is unlikely to be harmful. we say you need to continue all the time. You can't possibly stop after 3 months. Pregnancy is 9 months long, and you can't commit it to all of it. We continue anakinra through breastfeeding. If oral anakinra worked, we wouldn't be asking any of the patients to inject it. It really doesn't do anything via the oral route, and it's absolutely fine to have a bit of anakinra or indeed canakinumab in the breast milk. And we are not worried about paternal exposure, and I'll show you our rather limited data about this. That's a summary of 88 reported pregnancies, which I've just gone through, but on the whole, they have been fine. But one has to discuss with everybody before they get pregnant that this is a very small number of pregnancies to be talking about. So far it looks all right, but absence of evidence is not evidence of absence, and this has to be a discussion for everybody. But we are clear that stopping drug is higher risk than continuing treatment. We think the risks of letting somebody have very, very active disease all the way through their pregnancy is much worse for the pregnancy and for the potential baby than having a healthy parent providing a good environment in which to grow a baby. So what do you know about paternal exposure? This was our data from when we were doing drug trials, and we've made everybody swear blind that no babies were going to come out of the drug trials. It was probably the most fertile period I have ever managed patients in. So these are people who got their partners pregnant during drug trials. We had 6 anakinra, 6 canakinumab, and absolutely no problems. And these babies, this is a slightly old slides now, so these kids are now aged up to 16 years, and they've all been absolutely fine. So we are not concerned about the paternal side. The exposure to the sperm is actually quite brief, and it doesn't seem to do any harm at all. There is no signs of any sperm abnormalities. And again, with breastfeeding, we have not had any concerns with anakinra. With canakinumab, there is a theoretical concern about very, very early life vaccines. We have had a number of people who have become pregnant on canakinumab unintentionally. And what we've done then is ask them to not have any more, and when their disease becomes active, switch them to anakinra. We're not concerned about canakinumab in the breast milk, slightly concerned that a late dose of canakinumab might reduce our ability to make a live vaccine. We're not concerned about that with anakinra. So finally, what about the patient perspective? So these are a number of quotes from patients from our clinics. So the first is, my story is less about apprehension in conceiving whilst on the drug and more about the elation I felt when I finally fell pregnant. Convinced without this drug, it would never have been possible. Then the other one is, when I was around 25 at the height of my illness, I was diagnosed with infertility. I advised that IVF would be the path for me if I decided to have children. We had 3 failed attempts. They then came to us, said, we know we can't have kids. We failed it, put on treatment, got pregnant very rapidly. I'll come on to that in a moment. And then the third one is, in terms of apprehension during pregnancy, we're of course somewhat worried, given we didn't know whether the drug had an adverse effect. We got some comfort from the heart rate readings, scans, etc., showing signs of a healthy baby, who's since had another 2 children, all healthy. So we have had a very happy time with this. In our clinic, we've probably got 4 or 5 pregnancies going on at any one time with people on biologics, and about the same number with parents on colchicine. So what do we do? Our advice is, these are a number of our babies, all shown with permission, is start the conversation about this very early, long before anybody is pregnant or actively planning to get pregnant. So my teenagers all think I'm obsessed because they all know about this from very, very, very early. And we have the conversation in general very early, and then more specifically as they get older and as they meet partners and start to think about this. We have preconception planning. They know before they plan to conceive what the risks and benefits of maintaining therapy are. They know what their options are. That is documented, and they have a copy of the letter they can refer back to. At the same time, we talk about the risks of inheriting a genetic disease, whether they have a recessive disease or a dominant disease, what the risks of the child would be, how that could be diagnosed, what they could do, and that is also documented for them. We do talk about stopping treatment. We do talk about why I don't think that's a good idea. and then what the likely impacts of that are going to be on the parent, but also on any potential child. Given the lack of data with canakinumab, we switched to anakinra prior to conception or confirmation of pregnancy. We do careful prenatal screening of the renal tract. We tell people who we get late, who have already been told that they're subfertile, if we've made a diagnosis of active disease and we're putting them on a drug that will work, that they need to think about their reproductive choices, because we may find that they restore fertility, and that they need to consider whether they'd be happy with a pregnancy at this point, or whether they should be considering contraception, because we've had a number of people who had assumed that they had established subfertility, who got very pregnant very rapidly after disease was controlled. Don't promise it, but we say that's actually something you've got to think about. So our summary of a brief summary of the discussion is keeping the parents well is really important for the baby. You cannot assume that stopping treatment is a good choice for any baby. We know historically that active disease is associated with decreased fertility, increased pregnancy loss, prematurity, and small for date babies, and keeping the mum well throughout pregnancy reduces the risk of all of them. Good for the baby, good for the pregnancy. EULAR consensus guidance for colchicine is very straightforward, safe. It should be continued pre-conception throughout pregnancy. The data for anti-IL agents are less good. We recognize that a lot of what's written is very conservative. We have an individual benefit risk discussion with the family, ideally a long time pre-conception. We document that, and then we support continuing drug in the form of anakinra through pregnancy and conception. And we have seen unplanned conception due to restoration of both male and female fertility once disease is controlled. So we discuss birth control options early, even and particularly in people who think that's going to be a problem for them. And I'm going to stop there, I think, and we've done that one already. You're muted.
I'm trying to be smooth and I knocked my mouse off my desk, so I apologize. That was a fascinating talk. I personally learned a lot from your conversation, and I really want to thank you for coming today and talking about all of these things. We do have a couple of questions. So first, someone's asked if anakinra is still advised over Ilaris for patients with HIDs who are considering pregnancy, or is that something that you can talk about?
So it's tricky, and there you would need to come back to a very individual benefit risk discussion. So we have favored anakinra over Ilaris. What I would do with somebody who had not had adequate disease control on anakinra and had on Ilaris is difficult. I think I would probably increase the dose of anakinra first. But you are then left, if somebody really wants a baby, having the individual discussion and saying, if we can't control your disease with one agent, the options are to add in anti-IL-6, and although I didn't put it up there, the data for tocilizumab is also pretty favourable in pregnancy. But say what we have to do is to keep disease control to support the pregnancy, and we will do this with the lowest risk options, but that has to be tailored for each patient. So in general, I would, but in these very rare diseases, you can't go by what's written in the book, because if you do that, then you're not supporting pregnancy in anybody. So you then go back to having an individual risk discussion on whether they can be managed with anakinra or whether you have to think about adding in a second agent.
And how long before a patient is considering pregnancy would you recommend that they start having this discussion with their doctor? How long does it take for like the canakinumab, for example, to clear the system that they could confidently have a pregnancy without those risk factors?
So, I mean, as I say, my adolescent patients think I'm obsessed. We start with them in transition. They know, same way we tell them, they're not allowed to smoke. And when the time comes, they get this introduced very, very early, and then it gets more detailed. If they are planning pregnancy, we would ask them to have missed a cycle. So to have stopped their canakinumab and to have been put on anakinra with 4 weeks clear before they try and conceive.
Okay. So there's a question here also, if you can talk a bit more about the underlying cause of infertility in FMF and if low estrogen is ever a factor in that.
So from the frankly slightly scanty work that is there for us, there doesn't seem to be a specific reason why FMF should cause subfertility. So, and the difficulty with subfertility is it's very complex and very individual, but we don't think that FMF itself is a problem. If there has been, historically, there's concern that if there's been many, many years of active FMF, although it often doesn't scar, there did seem to have been some people who got some pelvic scarring, and that can mimic pelvic inflammatory disease. So you get enough scarring and adhesions that can actually interfere with how reproductive function works in women. Inflammation, recurrent inflammation reduces fertility, can do that quite obviously by actually clearly interfering with the menstrual cycle to the point of amenorrhea and also causing anovulatory cycles. And that's certainly how AA amyloidosis works. In people who are being investigated for subfertility, there are many causes found. There is no clear evidence that the FMF is causing that if it's controlled. So I think in people who are struggling with fertility, it's really important to control their FMF. But once it's controlled, what we tend to say is then to the fertility clinics to kind of ignore it, and we'll control their FMF and they manage the subfertility, but we try and take it out of the equation.
I found all of your conversations about the patients who regained fertility to be really amazing to hear. So it's really interesting that just controlling the disease so well can have such a positive impact on fertility. So a question has come in: what type of prenatal care do you recommend for patients? Is there anything in particular that they say, for example, high risk OB, a regular OB, or a midwife?
So assuming that we've got their disease well controlled and they have no other risk factors, we say have yourself a single doctor and ideally a small team of midwives who know what you've got, so that you don't have to have the same conversation every time about why you're taking your meds and what your disease is. And then we say we are remorselessly optimistic and cheerful about this. And we essentially say you'll be fine. Have standard prenatal care, but preferably not with somebody who's going to look horrified every time you mention your meds and tell you they're poisonous, because that's really dispiriting. But that's it. Otherwise, you try and say, we'll keep your disease quiet. They'll look after your baby. We've had really good outcomes. And just everybody shares each other's telephone numbers. But I mean, the problems we've had is somebody getting appendicitis at 32 weeks. And that was managed, I mean, very alarmingly for the poor person who had appendicitis, but otherwise very smoothly with phone calls between the medical staff and agreement. But otherwise, it should be fine.
Amazing. So are there, I know you've talked a lot about FMF today. Someone's asked if there are any other studies similar to the ones you did, but that monitor HIDs.
So there's not many in HIDs because it's so rare, and we pulled our HIDs in with our anti-IL-1 data. I'm just doing a head count in my brain at the moment of how many we've got. I think the difficulty with mevalonic kinase deficiency, so I'm big snotty, but we're trying not to call it HIDs, is that it is such a broad spectrum of disease. So many people do really well. there are a minority of people who've got really, really hard disease, and which is much, much more difficult to control. But we've had 4 people going through pregnancies on anti-IL-1 therapy, and it's been very smooth. But I don't think there's anything much more specific than that. And I fully acknowledge we probably ought to pull out the people with very, very difficult disease. And I don't think there are any publications that I know about that.
So someone's asking if there are any doctors with your specialization on this side of the ocean. They're asking particularly about the United States, but so there may also be Canadian people who are wondering the same thing. Or is there a way to get that same level of care that balances their autoinflammatory disease with their obstetric, their pregnancy as they're going through it, is a way to ensure their doctor is informed?
So it may be that Dr. Laxer, who's on, is a better person to ask that. Some of this is how health services are set up. And so we have not, it's something that is evolving, in that the number of physicians who are adult physicians who are interested in autoinflammatory disease is still quite small. It's growing. But it is true that at the moment, the powerful voices are in Europe, where also it may be a bit easier with how the health service is set up. But so I can't recommend anybody in the States, but I would say that the experience from France and Italy and the UK is that usually this is pretty good. And this is generally what we say is most people do really well on treatment, and it is the confidence to say we've had an honest conversation about the risks and benefits of treatment, and everybody's on board with that, and how to monitor. And it's stopping treatment that we worry about.
I was wondering if you could talk a bit about FMF and potentially other autoinflammatory diseases and the perimenstrual flares. So for a child who is approaching puberty, are there conversations you can start to have? Is there a way to prepare them? Conversations with the doctor? At what point do you consider putting them on OCP to manage those pains that like flares related to that?
So our experience is that this does seem to be much more of a feature with FMF than the other autoinflammatory diseases. And I don't think it's just because we see more FMF. I think there is more of a perimenstrual cyclical monthly pain with FMF that we see with the other diseases. So one, it is the conversation with girls as they go into adolescence about what is a normal level of menstrual discomfort and what is really not normal. It helps if they're old enough that they will tolerate a blood test, because you can get a very minor rise in inflammatory markers around menstruation. But if they're clearly putting them right up, it's an FMF attack. And then the other thing is, it is both very easy to get a little bit behind on your drug dosing with teenagers, because they still have the extremely efficient drug clearance that children have. Kids are just much, much better at dealing with drugs than adults. So they're chewing through the drugs because metabolically they clear them much, much more efficiently than adults do, but they're growing. So they're getting to be very big. So you have to keep chasing the drug dose up. And that can feel a bit alarming if you've been talking about one drug a day and then suddenly somebody's going, oh, we're going to go to 2, and then we're going to go 3 tablets, and we might be going to 4 tablets. And you're thinking, we've been chugging along on a tiny dose for years. What do you mean? Who's this person pushing the dose quite so dramatically? But then the other one is just, if it's coming every month, if they really are kind of clearly distressed and saying it was a bit like an FMF attack, we tend to go in fairly early. Say, does it get better? Partly because very strongly of the view that it's really important in adolescence that this is preferably, this has to be minimized for them. They need to go on every school trip. They need to go on every, they need to be at the parties. They need to be torturing their parents. They need to be having fun. And if you get kids with autoinflammatory disease, the small children need to do their catch-up growth if they haven't, and the teenagers need to party and be pushing their boundaries, and you really, really have to be on their disease so that they're not on their disease.
Right.
So
are there, talking about teenagers and partying, are there any specific concerns for teenagers regarding recreational drugs, alcohol, things that they should be more mindful of because of their disease condition? Not that we want to encourage them, but things that as parents maybe, or as teenagers, that they need to be mindful of, that there is still this, this part of their life that they can't just be the same as their friends.
So my line is, with the caveats about responsible parenting and responsible adults, is that the one ask is that they do take their drugs regularly, and that we can't change that. So that their medication needs to be in their most reliable bit of the day. So I'm very keen on same dose, same time of day, once a day, for whatever it is, so that they can do it and it's very straightforward. And beyond that, I do feel that if they are having to change compared to their friends because of disease, we haven't got their disease well enough controlled. So if there's a bit of, they're fine if they don't overdo it, but if they're overdoing it and they're too tired, they're getting breakthrough attacks. My line tends to be, we haven't got them well enough controlled. They should be having a normal adolescence.
Right.
And we should keep their disease well enough controlled that they can do that. You can't always do that, but that is very much what we say to them is the aim of treatment. And if we're not achieving that, we need to know so that we can do better.
I love that, but I'm also scared to be a mom of a teenager at some point. So question has come in too on, so we've talked a bit about oral contraceptive pill related to controlling menstrual flares or perimenstrual flares, but there's a question about patients on IUDs, oral contraceptives. Is there anything that they should be mindful of in any of the diseases that could cause flares?
There's no data for this, and I tend to give it back to the reproductive doctors. Certainly in Europe, I mean, Mirena coil has sort of taken the world over, and we're pretty happy having that. And we would say a non-hormone producing coil seems a bit retrograde, but we would put it back to the obstetrics doctors and say, what do you want to put in to achieve your disease aims, and that will probably sort us out too. So if this is for heavy painful periods, put in what you want, and it will probably do it for us as well. The oral data largely supports putting some progesterone in, which is what most of the hormone-eluting coils put into.
Okay. And so one last question on pregnancy. If an attack occurs while a patient is pregnant, what medications or treatment are specifically recommended that might be like for a breakthrough flare that won't harm a patient, the fetus, the child?
Okay, so that depends a bit where you are in your pregnancy. So Tylenol's always all right. There are some concerns about non-steroidals if you're too late in the pregnancy, because they have an effect on the one of the major blood vessels. So it tends to be, if it's really bad, that gets discussed with obstetrics about what analgesia they want to give. We try and keep it pretty tightly controlled and not have breakthroughs. If it's somebody who is on a biologic, we just double the biologics up. and say the data is pretty good that if you are on anakinra and you're flaring, actually another injection will often settle you within about 30 minutes. So we tend to just say, have another injection, see whether that will settle you down. On the whole, and this is really difficult because this is when the doctors are telling patients about their experience, which I get uncomfortable about. From my side of the screen, opiates aren't very useful. So when you do the data analysis, opiates aren't great painkillers, and what they often do is sedate people so that they're not telling you how much pain they're in rather than actually making the pain better. And I have some reservations about them late in pregnancy.
So that is all of the questions that have come in at the moment. I don't know if anyone else can wait a couple minutes to see if anyone else has any door knocker, door handle questions, as they say, on their minds. But personally, I have found this talk so fascinating to listen to, and I've learned so much, and I'm sure that I am speaking on behalf of everyone present where they've learned a lot today. So unless we have any other questions, I really want to thank you for taking time out of your very hot London day today to join us and provide us with so much information around these really important conditions.
Thank you very much. And I would say, these are diseases which have really changed in my professional lifetime, and they can be horrible for people to have. But for most people and around, family planning, our experience has really been very positive. Most people can expect to have a well-controlled disease and to effectively plan the family they want to have.
Right. I think that's wonderful. So thank you so much. We've just had one person writing to give voice to the same thing I did, that they have no questions, but they just want to thank you for your time and say how informative it was. So thank you again. We appreciate your time so much, Dr. Lachmann.
Well, thank you very much.
Thank you. Have a great afternoon or evening.
Thank you. Bye-bye.
Bye.